for joining today's webinar. And we are today privileged to have with us Professor Dr. S.Y. Kothari sir, one of the senior most member of our association who has keen interest in rehab surgery. Sir has retired recently from AIMS Bhopal as Professor PMR. So we invite you, sir, as chairing this session to give your critical inputs for this presentation. At the same time, also, I invite all the delegates, all the participants to this webinar. As you all know, clubfoot is a very common condition, otherwise called congenital talipes equinovirus. The otherwise called clubfoot. It's a very common condition. The prevalence is around 1.5 to 2 per 1,000 live birth. Still, there is poor awareness among health professionals, including doctors also, regarding early diagnosis of clubfoot or CTV, which leads to neglect in the management of clubfoot, leading to a neglected clubfoot. There is no universal definition of neglected clubfoot. I have gone through a couple of literatures to find out what is the exact definition of clubfoot. So in Journal of Child Orthopedics, they have said that when the treatment is not initiated before working age, that's called neglected clubfoot. Another article in Clinical Pediatrics Medicine Journal, they said that if there is no initial treatment or inadequate treatment, that's called a neglected clubfoot. Another journal says, article says that when the weight bearing takes place on the side or the dorsum of the foot, then we call it as a neglected clubfoot. But we consider that if the child has not taken any form of treatment till working age, it is called a neglected clubfoot. The condition is very common, and also it's important for the students' point of view, because most of the time in examination, students usually get a short case on clubfoot as it is one of the most common condition, congenital deformity around foot and ankle. So that's why I choose to discuss this topic. This initial picture is a idiopathic clubfoot. You can see it. The foots are supple, relatively supple, which can be managed by different plaster techniques and other methods if it is really identified in the early age. If failed to identify, they land with this type of deformity, and when the patient starts working, they work on the lateral body of the foot. Even sometimes the foot becomes so severely deformed that the patients work on the dorsum of the foot instead of plantar surface of the foot. So they develop this adaptive bursa on the lateral body of the foot and also adaptive changes in the bone. So we consider a neglected clubfoot where there occurs adaptive changes to the foot when the child started walking on the lateral body or the dorsum of the foot. So as I said, there is still poor awareness among the doctors, among the health professionals, among the parents, and we fail to convince the parent that the child should be treated as early as possible, even just after birth. So when that information is not reaching to the parents, they usually report to hospital in late age. Unfortunately, we get some patients in our OPD also where their parents are instructed by the health professional that don't worry, when the child will be walking age, then you can report to the hospital for further treatment. As the child limb is very soft in neonates, the child will not bear any form of treatment, but go on walking age, which is completely wrong. So it's because of lack of awareness among the health professional and the parents. So what will the initially the child the condition should be diagnosed from day of birth. If you look to this picture, this is just 2 days back a child reported to in our OPD, 7 days old child with right side clubfoot. If you this is a screening test, simple screening test, just dorsiflex the foot. If the seal of the tibia is touching to the dorsum of the foot, and that is possible just after birth. This child is after probably 10 days after birth reported to our OPD. So almost the seal of the tibia is touching to the dorsum of the foot. This is a simple clinical test to escape the child is not having clubfoot or CTB. This question is also often asked in the examination, how to exclude a CTB in a neonates. The same thing, if you look to this third picture, on the this is the right side foot, I'm trying to dorsiflex it, but still I'm not able to dorsiflex, I'm not able to touch the scene of the tibia to the dorsum foot. So this clinical screening clearly differentiate a neonatal normal foot from a clubfoot. So when awareness is poor, this is the situation. This is the photograph taken in 2002 in our old hospital. When at one point of time, just imagine the number of patients reporting to a hospital for plasticast or for surgery. This was a picture taken in 2002 in our old hospital building. Even for 10 years, in 2012, in our new hospital building, you can see still the prevalence of clubfoot. It is all because of that. These children are not being informed afterward that they should be treated with a plasticast or mother's manipulation. That's why they are reporting in the late age. So after 10 years of in 2012 also, the situation is the same. Again, another 10 years in 2022, last year, we have gone for a camp in a tribal area. Just see the number of neglected clubfoot children at one point of time. So this says that there is some lacuna somewhere that these people are not well informed or facilities are not extended to the children, or the doctors are not well trained to treat these children in early stage to prevent the occurrence of neglected clubfoot. So somewhere we have a responsibility to spread this knowledge, or we train ourselves to treat clubfoot in our level so that to decrease the incidence of the prevalence of clubfoot in society. So this year in 2023, we have published a paper in June early, this year June, that is a neglected clubfoot, a community health challenge in rural Odisha. In fact, it is really a challenge in the rural sector. So whatever clubfoot we are seeing in our institute level, that's just a tip of the iceberg. Actually, the number is quite high in rural area. They're quite high in tribal areas where the healthcare facility is poor, the awareness is poor. So this is data published in our study. We have shown it that if the prevalence rate in an Indian study is 0.96 to 1.42 for 1,000 live birth, and as per Niti Aayog, the population strength of India is approximately 1.34 billion with a birth rate of 17.53 per 1,000 population. So taking the higher side of the clubfoot incidence 1.42 per 1,000 live birth, we have calculated that the estimated number of children born with clubfoot in India is 30,000 per year. So exactly the same magnitude of problem we are not getting in our institution level, but the magnitude is quite high in rural sector, all because of lack of awareness among the health professional, and it is our responsibility since it is coming under disability category. In the last 2016 PWD Act, the clubfoot has been included as a disability category. So it is our responsibility is that we must spread the awareness of diagnosis of the clubfoot. We must learn the methods of management of clubfoot. We must learn the methods of managing neglected clubfoot. So in this from 2014 to 2020 to except the corona year of 2020 and 21, within 7 years, we have retained 993 feet of 7,731 clubfoot children in rural sector. So we have gone through the real magnitude of the prevalence of clubfoot in this rural India. So if you come in to classify the club foods, they are basically we get the institutional level is the idiopathic club food, which is very much subtle and we can treat very well with plaster casting and different methods of treatment. And when they are not treated, they can become neglected. And some club food, like associated with some neurological conditions like spina bifida, collagen disorders like arthrogryposis. So these conditions are very much rigid, but still plaster has a great role. Even if rigid condition needs surgery, need auto intervention, but still plaster has always a great role before even going for surgery. If the patients are not aware about the parents are not aware about the post management, post correction management, there is only possibility of recurrence. Even after complete correction of the patients, the deformities are relapsed because of poor compliance to the breast. So as a PMR specialist, as a physiatrist, when you treat a clubfoot child, our moral responsibility also that after treating also you have to explain that this is a condition which is likely to recur if the brace is not used for 23 hours a day or the proper follow-up in proper interval is not followed or not. So if that is not followed, there is every chance of recurrence and it is a burden to the parents, it's a burden to the society and it also increases our expenditure and manpower at the institutional level. So what happened to the neglected club food? How it is different from the normal idiopathic club food or a supple club food? So as I said from the beginning, a neglected club food is a club food which which we call when the child started walking on the lateral body of the foot or dorsum of the foot. So when the child started walking, there occurred some adaptive changes in the foot. The bones are no more in normal shape; they become changed with pressure with walking over the dorsal surface of the foot. So what happened to the talus? Talus is the main culprit here in the club foot. That is the least displaced and more deformed bone. The rest of the bones are displaced around the talus. So talus is the least displaced bone. What maximum deformed bone? So what happened to the talus? Talar head became conical in shape in case of neglected club foot. The navicular is almost attached to the medial. If you look to this picture, the navicular bone is attached to the medial surface of the neck of the talus instead of the other head of the talus. So it is displaced medially and plantarwards and becomes wedge shape. No more became navicular shape, no more became boot shape, that became a boot shaped navicular bone. The same thing also happened to the calcaneal cuboid joints. When the child walks over the left bone of the foot, it is the right to the calcaneal cuboid joints and they develop adaptive version of the calcaneal cuboid joint. Okay, and that like a cushion. So the calcaneal cuboid joint became no more horizontal, that became oblique. That creates another problem, resistance to the other manipulation methods or plaster casting. Then subtalar joint is held in maximum position of supination. If you look at this foot, this is completely supinated foot, completely inverted foot. So there also it's difficult to reposition the bones when it is completely deformed or it is completely displaced. So we must understand what happened to the bones in a case of neglected club foot, and accordingly we can plan our treatment. Next part is assessment part. Before that, I must tell something about the clinical examination of the club foot. In case of examination, students usually go to say straightway it is club foot, small foot, crease like that. So it should not be presented in this way. It should be present in the same heading we present like other musculoskeletal conditions in the form of inspection, palpation, movements, measurements, and special test. This way, we can examine the club foot from inspection, short foot, curved lateral border, all inside the callosities present in the lateral border of the foot. This way, all inspectory findings, palpatory findings, palpate the head of the talus, palpate the calcaneum tip to classify into the Pirani score. So palpation is important here. Palpate the medial crease, how depth it is, So in palpation method, and if palpate any adventitious bursa is infected, warm, so that all comes under palpation. Movements, you try to see all movements around the foot and ankle, like ankle movement, subtalar movement, what is the extent of fixed deformity, measure the varas and the calcaneus inversion or the varas of the foot. So all these things are asked in your examination. Don't jump straight to this club foot and pyramid score this much and that. No, not in that way. They examine the foot classically as you examine in a case of musculoskeletal conditions. So besides the clinical examination, radiological examination includes X-ray. This X-ray is not so important in case of small kids, in case of supple foot or idiopathic club foot. There, the most of the time, the calcaneus or the tarsal bones are cartilage in nature. It is difficult to draw the lines, but shortly if the child is neglected, say 3-4 years age, you can very take a epi view and lateral view of the foot and ankle, and you can measure the axis of the talus, axis of the calcaneus. You can measure the talocalcaneal angle. You can measure the talophosphatidal angle. These are not for diagnosis purpose. These are just to help you for research purpose to see whether your modality of treatment is working or not, whether it is food is correcting or not. For research purpose, it is required. It is required for any legal procedure. Sometimes as evidence you can say, no, the talonavicular angle was this much. With my treatment, the angle has changed. So these are the utility of radiological X-rays and investigations. However, it is not required for the diagnosis. But out of all assessment criteria, the so far pyramid score, everything using the communist assessment method. We'll discuss in this detail in the next slide. It is often asked in your examination. Define pyramid score. What are the different scores? How to see the scores? This we'll discuss in the next slide. Other less commonly used are remaining scores, international club study group outcome evaluation system, not so commonly again for research purpose, and clubfoot assessment protocol. This international clubfoot study group and clubfoot assessment protocol, I would like to highlight here that this is a assessment system which is as per our international classification of functioning methods of evaluation. This pyramid score, Diminished score, these are cross-sectional studies. Just at that point of time, they never consider about the function of the and participation, activity, and function are not included in pyramid score and Diminished score. They are only concerned about the any function, any impairment in structure. It's not related to in function. So it has been observed that yes, a functional score is required as per the ICF classification. So these two classification system are followed. ICF classification system. Accordingly, the clubfoot assessment is done. Other methods are quantitative clubfoot assessment of deformity, quantitative 100-point rating system, and short form 36 also can be used for assessment of the your treatment, how the patient has benefited, with your treatment can be assessed for research purpose also. Short form 36. Foot function index can be used. Currently, we got through literature in JCT, Journal of Clinical Orthopedic and Trauma, published in 2020. They have taken a protocol in NWDPS protocol. So A stands for no pain and during walking or running. W stands for W was ability to wear normal, so whether the child can use a normal shoe or not. D means was not significant different in the foot or shoes, whether there is difference between two foots in shoe size or in foot size on both the sides. P means plantigrade foot, whether the foot is plantigrade or not. S means whether the child can squat without heel lift up or not. So this is a very basic thing. So it's a very beautiful way one can also assess the treatment pattern by this NWDPS protocol. So coming to the most common assessment system is pyramid score. So if you look to this picture, there is a very simple way you can learn that there are two scores, basically midfoot score and hindfoot score. Just imagine what components in a club food, and accordingly you can measure it. They are, as per severity, they are either mild or moderate or severe. Mild score as 0, moderate score as 0.5, and severe score as 1. So if you look to the midfoot part, midfoot means it is talus and distal warts who are stored. So look to that, there is always a curved lateral border. There is a curved lateral border always in all claw foot. Since the foot there is associated foot adduction, so there is always a curved lateral border. And see how extent the curve is. Whether the curve is a round curve or the curve is the, if you put a scale here on the lateral border, where from the curve is bending, what from the foot adduction is there. Okay, if it is a round curve, then and it is 0, and when it is not, when it is at the metatarsal base level, it is adducted. If the foot is adducted at the calcaneal joint, that's a severe form of adduction. That's called a the score is severe. It is score as 1. So put a scale on the lateral border of the foot. See from which part the foot is getting bent. The foot is getting bent from the metatarsal base, it is 0.5. If it is foot is getting bent from the calcaneal joint, it is 1. Look to the midfoot crease. This is a, look to this picture. This is, look to midfoot crease. Look to the crease. Where if there are multiple creases, it is 0. If it is 2 or 3 creases, but the base is well visible, the base of the crease is well visible, then it is moderate. If the crease is single crease, big crease, where the base of the crease is not visible, that is severe varieties and scored as 1. So that is medial foot crease score. Then talar head. How to palpate talar head? Palpate the lateral malleus. Here is the lateral malleus. Palpate the lateral malleus. Go interiorly. Go towards the dorsum of the foot. The first bony palpation you will feel, that is the talar head. So see whether the talar head is prominent, talar head is reducible, talar head is not reducible. If the talar head is well reducible, correcting the foot adduction, that means it is very mild and score is 0. If the talar head is partially reducible, still is palpable, then it is not. If the talar head is completely palpable even after trying for correction, then it is called severe score as 1. So this is about midfoot score. I hope you all understand now what is Pirani midfoot score. Then hindfoot score. Hindfoot score, this is if you look from the back of the foot, this is the posterior crease. Posterior similarly like medial crease, if there are multiple creases, it is 0. If it is 2 or 3 creases where the base of the crease is visible, it is 0.5. If the crease is single crease here, the base of the crease is not well visible, it is severe and measured as 1. So this is posterior crease. Then rigid equinus. You try to correct the foot equinus. If you are correcting fully, then it is a mild or 0. If it is maximum coming up to plantigrade, not going to the dorsiflexor, then it is 0.5. If it is not coming at least to plantigrade, that means still remain plantar flex, even by passive correction, then it is severe or grade score as 1. Okay, and the last clinical parameter is empty heel. Empty heel, you palpate the heel. If the heel is well palpable, it is 0. If it is topped up, fat part is here, but still on pressure, still you can delineate the calcaneus, then it is 0.5. If after thorough palpation, if you get only fat pad on the heel and the calcaneus is not palpable, then it is 1. So if you calculate in the scores, all the scores are very severe. So the score will be 6. And if the score is 6, then this is coming under a disability category. In neglected club group, they will get 40% disability. Even less than 6, then it will they may come under disability category, but the benchmark disability will not be, they will not touch it. So This is how you can assess the clubfoot, score the clubfoot, score the severity of the clubfoot by using pyramid score. Now, the coming to treatment part. So far, the consensus method of plastocasting is accepted worldwide. Initially, it was Kite's method, when the fulcrum of the correction of the varus deformity was the calcaneal cuboid joint. Now, the current method is the consensus method, where the fulcrum of correction is at the talar head. So, the manipulation methods have changed now. In Kite method, we were correcting the deformity. We are trying to first correct the purpura adduction, then varus correction, then equinus correction. The current concept is changed now. As per Ponseti's method, we first supinate it, try to make align all the tarsal bones and metatarsal bones in one line, then try to external rotate it. By that, we correct supination, we correct purpura adduction. So that is Ponseti's method. I don't want to go in details about this method, since our today's discussion is on neglected clubfoot. So whether the Ponseti method is useful for the neglected clubfoot or not, we'll go through the different literature and see that what the literature says about the management of neglected clubfoot by Ponseti's method. So I would like to again request all our PG students, young physiatrists, try to learn the technique of plastocasting. It is not only for the clubfoot correction. The plastocasting method, learning the technique of applying plastocast is very much helpful in the other conditions of deformity correction. Say it is a traumatic brain injury, say it is a spinal cord injury, say it is any other bone contracture. So many deformities can be corrected with plastocast by gradual stretching and plastocasting. So all students, all physiatry students must learn the technique of plastocasting. Don't leave the plaster technician. Try to know methods of wrapping plaster, how how you apply the plastocast on yourself. So you should try to apply plastocast without leaving to the technician. So that learning is always helpful, this plastocasting. So I have gone through certain literatures regarding whether the Ponseti's technique is useful for the treatment of neglected clubfoot or not, but still I did not find a common consensus about this. So there is a literature here in 2001 published that the upper age limit for the use of Ponseti method in clubfoot treatment is yet to be established. So that means there is no bar for treating neglected clubfoot with respect to age. So at any Ponseti method can be used. There are a couple of studies, although the single study, the sample size are very small. Like this study, only 25 fits they have taken with children of more than 7-year age group. They have used Ponseti's method of plastocasting. This is another study from Ethiopia. They have used only 32 fits in 22 children. And there are multi-center studies there. Here, this is one more study where multi-center study, they have taken 225 patients. They have used this treatment of clubfoot, neglected clubfoot by Ponseti's method. This study is from Nigeria. There are another study also, 30%. This is from India. They have used, it's published in Indian Orthopedics, 30%. So still studies are lacking. Someone can take a challenge of taking more number of patients for see the effect of Ponseti's technique on correction of neglected clubfoot. So although we are lacking in devising methods of correction, we adopt Ponseti's method, and we are lacking knowledge of putting plastocast, we are lacking knowledge of applying Ponseti's method of technique for correcting plastocast, but still in Western world, physiotherapists also treat clubfoot by French functional method. So this is the method devised by physiotherapists. So it is not that the clubfoot correction is only for the orthopedician or only for physiatrist. Anybody, any pediatrician any physiatrist, anybody can treat. Even the physiotherapist can treat a clubfoot children. Why not a physiatrist? So we all should know the methods of management of clubfoot. This functional methods of clubfoot correction by devised by Physiotherapist Association that they have treated in such a way that daily manipulation of the patient intense clubfoot, stimulation of the muscles acting on the foot to maintain the reduction achieved through manipulation. That is, those muscles which are contracted, those muscles which are relaxed, the contracted muscles are stressed and the opposite group of muscles are stimulated. Like the plantar flexors are stressed and dorsiflexors are stimulated. So they stressed and they maintain correction by non-elastic adhesive strapping. They try to maintain the correction instead of using plaster cast. They have used adhesive plaster casting. In addition, they strengthen opposite group of muscles. In fact, they are psychologically strong that they can prevent recurrence by strengthening the opposite group of muscles, along with the stretching of the contracted structures like tibialis posterior, stretching of the tendon Achilles. So this clubfoot treatment is open for all. The next part is surgical treatment. As I said, that the plaster casting may not be sufficient in a case of neglected clubfoot when the deformities are already established. There is already adaptive deformities like this foot. That already adaptive deformities there. So it's difficult to realign the wounds. So the surgical methods are adapted, but you may not have facility of surgical in all centers. Today I will show you also some techniques where a minimal surgery along with the plaster casting can help in correction of neglected clubfoot. I will show you some pictures for your interest also. So as far as surgical treatment is concerned, there is no single surgical procedure to correct a neglected clubfoot. So the surgical procedure depends upon the severity of the deformity, the severity of the bony changes, the severity of the malalignment of all the joints. So all these factors depends upon what type of surgical procedure to be adopted. So as the child reported in early, soft tissue releases are most useful, but when the patient present in late phase, probably only soft tissue release is not sufficient enough. You have to add something more to that. So that time, soft tissue release along with some osteotomy is required, or sometimes arthrodesis is required, but the relapse rates are very high. So deformity must be well corrected and well maintained for a long period. Minimum 3 months must be utilized to prevent recurrence. So all the procedures, the selection of procedures depends upon age, severity, and degree of flexibility of the neglected clubfoot. So this is algorithm I have taken from Techniques of Orthopedics, published in 2005. So what is how to go with how to decide what type of surgical procedure required in case of neglected clubfoot. This is an algorithm which is published quite old, say around 18 years back. So we'll discuss all the one current one, but still some of the procedures are still accepted today also. So initially, all the patient, even present in neglected condition also, should be treated with plaster cast. Please, I repeat it that how extent is the deformity, how severe is the deformity. Start try with the plaster cast. That may not be the deformity, but at least that increases the skin elasticity for your future correction. So plaster cast irrespective of age at presentation. So after few plaster casts, when the skin becomes soft, become elastic, then you can go for further correction. So if the deformity is flexible, you can go for posteromedial release. If the little bit stiff foot, then there are other different methods of soft tissue releases are there. Medial release, along with lateral release, by Cincinnati's method, there we release calcaneocular joints also along with the calcaneocular ligament. And once it is corrected, sometimes they present with some residual deformities. If there is a persistent adductus deformity, foot adduction deformity, then obviously there will be increase of lateral curvature of the bone there we'll have to go for a lateral column shortening, lateral foot rib shortening by doing a closed wedge osteotomy. We'll discuss details in the subsequent slides. And if there is persistent equinox, sometimes you corrected the foot by plastercast or by surgical method. After a few years, they come with some components of deformity, maybe equinox deformity, maybe only varus deformity, maybe supination deformity, including inversion and plantar flexion deformity. So they are depending upon what deformities patient is presenting, you have to decide the treatment. So if there is a persistent equinox, then maybe you have to go for a TA lengthening not corrected by tender the excision of the head of the talus or posted in the tibia. So as I said, this is a quite old picture, old publication. These things are no more followed now. But however, the deformity is very severe, then one can go for triple arthrodesis. Very accepted procedure, triple arthrodesis can correct the deformity in one go, which a disadvantage that the foot will be small. So you have to take a lot of weights. Talectomy is a procedure reserved for the arthrogryposis patient where the deformity is very severe. All the long tendons are fibrous, thick, cord-like. They are not malleable. So to correct the foot, the whole talus has to be taken out. That's called talectomy procedure. Still, these conditions are no more practiced now with the advent of different fixator methods. This is a current one published in 2022. This algorithm last year published in International Orthopedics. As per this algorithm, if the child is presenting in less than 2 years age group, the pulsatile casting is the best method for treating the clubfoot. Even the child is in neglected condition, no, it's a virgin foot, has not undergone any sort of treatment. Still, one can try with the pulsatile plaster with minimal invasion like TA lengthening or abductor hallucis stenotomy, that or the plantar fascia relief. With minimal procedure, plaster casting will be good enough to correct the deformity. If the child is still present in very late age group within 2 to 10 years age group, then we have to go for surgical procedures like posterior release has to be done. But again, go for plaster cast first, then go for surgical release. And it depends upon, and this is a regimen they have given what is the duration of non-weight bearing cast. So upper leg cast with 30 degrees of flexion at the knee joint. So it should be non-weight bearing, then weight bearing. So it's a there is a old concept that also the child bears weight, the ground reaction for the best method of the maintaining the correction. That holds true also. You correct the deformity, put plaster cast, ask the child to walk over the plaster cast for a few months more. The patient present in the latest. So that's the best way to prevent some recurrence. As the child bears weight over the plantars of the foot, the ground reaction force itself acts as a correcting force. Okay. Then when the child presents more than 10 years age, then probably this correction of soft tissue surgery may be not adequate. Most of the times they require bony procedure like triple arthrodesis, as I said, is the best method of treating a neglected clubfoot of more than 10 years age group. So again, if the initially you have treated the plaster cast, the child presents with some recurrence in late age, depending on the residual deformity also, the methods of PNM management different. If there is a residual hindfoot equinus deformity, then serial casting with progressive dorsiflexion of the foot, residual hindfoot varus, then maybe you have to go for lateral closed wedge osteotomy of the calcaneus, otherwise called varus osteotomy. If there is a residual forefoot equinus, that means the forefoot part is equinus, that means cavus deformity is associated. Then probably you will have to take a dorsal wedge osteotomy. Old method is called Japas osteotomy. You have to take a dorsal lateral wedge to correct the deformity. And if the all deformities are there, equinus is there, varus is there, forefoot adduction is there, cavus is there, maybe the triple arthrodesis is the best method. So today I want to show that if you don't have a facility of arthrodesis, I mean bony procedure, you don't have expertise, you don't have facility of going for any bony procedure. So you can correct the deformity neglected clubfoot also by knowing small soft tissue procedures. So let's say tail lengthening, a plantar fasciotomy, adductor hallucis stenotomy. These are only small soft tissue procedure along with the plaster cast can well correct your foot. So nothing to worry that you don't know about the osteotomy methods. No, you can correct it also. So if the patient present in the early stages with the soft tissue supple foot, you can go for a complete soft tissue release, which is no more accepted now. But these foods are better managed by conservative method. It has been seen that in even PMS also the child is coming back with a stiff foot when you go for extensive release. Earlier, the extensive release was more popular to correct severe deformity. But now the current concept is that extensive release is contraindicated. Go for as minimal release as possible, and rest of the things can be managed by plaster casting. So extensive releases are no more acceptable now, but everywhere the a la carte is acceptable. A la carte means the as you order in your food a la carte as per your choice, as per the requirement of the food, as per the requirement of the deformity. Only touch those sections only. Don't extensively release all the deformities if the deformities are not established. Okay, that's a la carte procedure. So I want to show this is simple. This person still in our work. If you see that this foot is not so severe, but this foot is a severe deformity, the foot is not obvious in the this sitting person. If the child is standing person, this is the status of the left foot. See, this looks benign, but when the child is standing, he is standing on the left part of the foot. The whole plantar surface is facing upward. So that means this is a neglected club foot on the left side. Right side is neglected, but the virus deformity is prominent. So this was the gate of this side. Just look how he's walking. He's almost walking on the lateral body of the foot, and the plantar of the surface is facing off. Okay, so this patient we manage by a simple soft tissue method. And today we were the last waging for her. Today we corrected the left one. It was the deformity is not fully corrected. This side, right side was fully corrected. This side was not fully corrected. And today itself only we did the wedge cast and correct the deformity. So I need to say that there are wedge cast methods are there. The technique of wedging is there. You can go for a wedge cast, very simple method, wedge casting. By that, you can also correct the severe deformity. So this is the same child. We have just done only tail lengthening in this case. By tail lengthening also, we could correct the severe deformity of the foot, left foot. Right foot, of course, it is not so severe, but both foots are corrected by simple plaster casting with only tail lengthening. Tail lengthening and plantar fasciectomy. Release of the plantar fascia. So I want to highlight this method with casting. This casting, all students, all physiatrists can do plaster casting. So by doing simple tail lengthening, the same child I saw in the previous slide, the same child. So this is the way how we do wedge casting. Like in case of club foot, we have a varus deformity, we have forefoot adduction deformity. So the wedge to be taken here is the it should be open in the dorsal side and lateral side, so that we correct by manipulation under anesthesia. This is a simple video I can show you. So this is was described by Dr. Aja or PG. So this is way how we mark the wedging, and we take out this wedge dorsally and laterally and try to correct the deformity. And this is the most simplest way of correcting the deformity. If you don't have expertise of doing osteotomy, the foot can be corrected by wedge casting. Yes, you have to take some care also during taking wedge. You are the different methods of wedging cast. So after taking this wedge, you have to go for a dorsal release here cast, and here if you don't go for adequate padding and adequate taking of the wedge, there is a possibility of the sores like this. The child may develop a dorsal sore if you manipulate it without properly cutting the wedge anteriorly and dorsal and laterally. So this is simple method. I want to highlight here that the severe deformity can be corrected by wedge casting. Other methods are there. Probably all centers don't have facility of doing this UMX method, or now the Indian version has come up like called JS method. The deformities of 3 to 5 age group, where the bone is very much cartilaginous. You cannot take weight of the bones for correcting the deformity. This is the simplest way, and you cannot use IAPMR also. IAPMR will be too heavy for those children of less than 5 years age group. So this is the UMX Indian version JES, Justice External Stabilization System, is the best method for correcting the deformity, but however, it has a steep learning curve, may not be available everywhere. This is just for your knowledge. This is a method for correction of deformity. Another method is IAPMR methods of the deformity correction. This is powerful method of obtaining correction of a severely deformed foot. The beauty of this method is that you can correct the deformity progressively. The deformity will correct in front of you. The way you turn the screws, so you can go on gradually correcting it. You can have the joystick with you by playing with the distracting rods. This is also a simple method. Even our students also doing this can apply laser method. However, if the facility is not there, also nothing to be worried. I want to show a comparison. This is, you can say, the severe deformity, severely deformed neglected club foot treated by laser method, fully corrected. But if you don't have that facility, nothing to be worried. This deformity can be corrected by plastic casting also. Look this side I have already shown in the previous slide. This side I had also, she has also bilateral neglected club foot. Okay, so as a trial method, we are correcting one side with laser method and one side with plastic casting. So no, for your surprise, even if you see that this is a laser method which is taking a long time for correction, but see, we have done only soft tissue procedure here. The next 2 or 3 wedge cast, we can correct the deformity fully by simple casting method. So if you don't have the opportunity or facility of putting laser, you can correct by knowing very small soft tissue procedures followed by plaster cast. I hope the result of laser will be as good as the result of casting will be as good as the laser method for this side. So we are comparing both the foot, one foot with laser, other foot with casting. So as I said, the casting is within our reach. We can manage a lot of foot deformities by casting method. And however, other methods are there. Bony procedure, if you have that skill, or if you want to know also different methods, there are different centers are there for training you about the deformity correction of the foot. So just for your knowledge, that depending upon the deformity, if there is a varus deformity at the heel, fully isolated varus deformity, we can go for calcaneal osteotomy. This is calcaneal. We take a wedge on the lateral side just to make the lateral column soft, just to make the lateral border of the foot straight. So calcaneal osteotomy is varus osteotomy, or we can do orthodosis here, taking a wedge from the tuber, taking wedge from the calcaneum, taking a piece of bone at this joint level, trying to shorten the lateral border of the foot to make the lateral border of the foot straight. So that can be done as a bony procedure. The deformity is very much severe. You can add medial side. So if you shorten the lateral border, it will be straight, or also you can lengthen the medial border. Lengthening the medial border is possible by doing a open osteotomy at the medial cuneiform member. Okay, so if the child has presented very late after 10 years or 12 years, straight to one can go for triple orthodosis. And nowadays, midfoot osteotomy also is doing good for 5 years, less than after 5 years age group, we can go for midfoot osteotomy. Here, you just have to take a wedge, dorsal wedge like this, and making the foot straight. Don't go for extra findings. Extra will be very bad looking, but the foot will be straight and it will be painless. So these are a schematical presentation of different methods of correcting the lateral border of lateral curvature of the foot. correcting the virus and purpura adduction is a method where we have done a chunk of the bone is removed from the cuboid, from the calcaneum, and fused it to make the lateral border straight. So this is another method also by again by taking a piece of the cuboid bone here, making the lateral border straight, or you can go for medial open wedge osteotomy of the medial cuneiform. So these are different bony procedures. I don't want to go details about this. This is a method. If you have basic knowledge about osteotomy, it's a very simple way of correcting the deformity. Besides plastic cast, just say with a small incision, we have just taken a wedge, dorsolateral wedge here, and the dorsolateral wedge will be from the navicular bone to base of the metatarsals. Just a take of wedge, try to straighten the foot. Okay, with this small incision, the separate elevate all the extensor group of muscles, dorsalis pedis artery, anterolateral nor medially, and protect the peroneus longus tendons by this retractor. Now, in front of you, nothing is there. Only extensor digital brevis is there. Lift it up, you are straight on the bone. Take a wedge of the bone with the base dorsally, and you can correct the deformity. These are results of the midfoot osteotomy. You can see it here. The severe deformity has been fully corrected. Lateral displacement calcaneal osteotomy is reserved for an adult patient with only isolated varus deformity. Then, like we planovalgate foot, we go for medial displacement osteotomy. Here also, lateral displacement osteotomy hold good for isolated varus deformity. So, as I said, triple apheresis is the best method of correcting the deformity in neglected club foot in ages more than 12 years age group. Nowadays, this method is reserved for neurological conditions like spina bifida or arthrogryposis collagenate disorders conditions, arthrogryposis conditions. But rest of the neglected club foots can be managed by different distraction methods. This is a clubfoot child, bilateral neglected clubfoot. So severe deformities, he was walking almost on the dorsum of the foot. The plantar surface is looking up. You can see that foot is plantigrade. The thing is that just imagine this picture. The child reported off with his school frock. And child, after 3 months, also she is using the same frock. Just see the poverty of the child. This child cannot reach the Wadi Hospital, Bombay for correction of deformity. This child cannot go to any National Institute for Correction of Deformity. So you are the people, we are the people in the periphery who can help the children for the correction of deformity. And this is not a concern. Just look into this photograph. It indicates that what is the economic status of the child who is coming with a frog at the admission stage and at the discharge also, and after 3 months follow-up also, the child is wearing the same the same frog. That indicates the extent of poverty of that child. So we are the people who can help these children for correction of deformity, little increasing our knowledge, little increasing our competency. Yes, we can treat the children. What competency you have? If you are thorough about the plastic casting, use that technique with small soft tissue procedures. Yes, you can correct the deformity. Talectomy procedure where the talus is completely removed. This is the reserved procedure for the arthrogryposis conditions where the muscles are all fibrous, cord-like tendons, no fat. So difficult to correct the deformity. The talectomy is a procedure. However, it is now no more accepted because other distraction methods have come up. So summarizing my presentation, that this neglected clubfoot is not a myth. You can treat the patient by adapting as per your competency and your expertise, little bit improving your competency, little bit improving your technical expertise. You can also treat a neglected clubfoot. You can, by that we can decrease the burdens in the society. So don't try to follow a single method of correction. You can customize depending upon the condition. So you have to think about the education of the patient, socioeconomic status of the parent, how much they are compliant to their treatment. That's most important thing to prevent the recurrence of the deformity. And age at presentation, you have to look for at what age, what are the bones are mature, which bones are not mature. When you go for osteotomy, when you go for casting, and resource facility at your level, you can try to improve your resource facility. When therapists can treat a clubfoot children, when therapists can design a method of treating clubfoot, why not a physiatrist? So I urge all physiatrists, all students to join hand for treating clubfoot and this decreasing the disability burden resulting from a common disability or common congenital condition of foot and ankle. Thank you very much.
Thank you, Pabitra. Nicely
Thank you, sir.
presented, but you have presented a very wide topic in a short time. You
Sir.
should have fragmented it into 4 pieces because
Sir.
you are an orthopedic surgeon and I think your aim was towards PMR students.
Sir.
So
Sir,
for them to understand this,
sir.
for them to understand this deformed anatomy, it's a very difficult thing. You should have presented it in 4 pieces so that
Sir.
they can understand it properly. You have presented
Sir,
very nicely, very nicely, but it's a very compact presentation. Anyway,
sir,
thank
this
you.
all last 4-5 slides, I don't want to show these things. My point of focus was on the wedge casting. Sir, I have learned this method few days back only from Jaipur.
You are an orthopedic surgeon?
Sir, I am a physiatrist, sir.
Not orthopedic surgeon? Hats off, you are really gained quite a lot of this thing, experience and techniques. But for an average PMR student, it's a very difficult thing.
Sir, casting must learn by all physiatrists, all our students casting, they must learn the casting.
Wedge casting and correction is a very dangerous procedure. It leads to ulcer formation very often. So you should be cautious in teaching to students. Number 1.
There are
Number 2,
simple
giving any stepping procedure to physiotherapist, I will not advise.
Sir.
What is yours and keep it up to you.
Sir.
Don't give it to them. And hats off to your skills, orthopedic skills. Really, you should have done added MS or DNB ortho. Very good.
Sir, actually, my point of presentation for this topic is regarding wedge casting, sir. This is a simple method. If you learn, yes, every method has its own complications, but we must learn to know what are the expected complications and how to avoid those complications. Whatever procedure you are learning, students, whatever procedure you are learning, you must know that what are the advantages, what are the disadvantages, what are the complications, how to avoid the complications, what method you follow. Whether you give an injection, you give an intraarticular injection, whether you give any form of intervention, all interventions are their own complications. So if you're afraid of the complications, will not go ahead. All complications are there. We must learn how to avoid the complications, how to minimize the complications.
Very right.
Then we can learn a procedure.
Very right. You should have kept focus on the this thing, cast correction, wedge correction on that.
So we'll come up with a video programs with casting methods.
Very right.
Shortly.
Very right.
Yes, sir.
Absolutely right.
Techniques of wedge casting by video demonstration. We'll go with that. Definitely, it will be helpful our students for knowing the. It's not for the clubfoot even. This wedge casting is helpful for other deformity corrections also. So that's a very beautiful method of correcting the deformity. We'll have one more session on that video demonstration of wedge casting.
Sir, one question is there, sir.
Yes, please.
Sir, how much abduction will be there before doing tenotomy?
How much?
Abduction.
Foot abduction is there. So as for consensus method, the tenotomy is always used when there is a pyramid score is 0.5, hind foot score is 0.5. That means all the deformities are corrected. Only the foot is not going to dorsiflex. It is coming to plantigrade only. That is the classical indication of doing tenotomy for as per the pyramid's this concentric recommendation. But This several papers has come up now that tender is one of the main culprit of deformity prevention of correction or late correction. So one can go for TA tenotomy. Even papers are published up to 8 years age group. You can go for TA tenotomy. What you should do with a 15 number blade. There are special techniques. You have to keep the tendon sheath intact. Only cut the tendon. So there is a special technique for that. If you do tenotomy, even up to 8 years age, it has been proven in MRI study that the tendon is regenerated by doing a percutaneous tenotomy. So tenotomy can be, if you are doing a classical conservative method, tenotomy should be done when the peroneal score is 0.5. Other methods of neglected clubfoot correction, yes, you can go for tenotomy or tear lengthening at the beginning stage, then followed by plastic casting.
Okay, sir.
Saurav, we can take questions from the chat box if any other questions are there.
Thank you.
Sir. I'm checking, sir.
Sir, using sir, join sir. Namaste, sir. Sir, do you have any comments on or any advice for participants?
I was absolutely overwhelmed. You teach so well and you have such vast clinical experience and you have also published. You are an example for every one of us. Thank you.
Sir, your blessings are it is not
Sir, selection of patient for JACE.
This is quite complex. So as I said, this is not coming under physiatrist point of view. Anyway, I can answer that to that. JACE is a external stabilization system. This is a distraction method or external fixation method, which is normally adopted in 3 to 5 years age group. Because 3 years age group, if you go for osteotomy methods, bones are cartilaginous. It will not arthrodesis or fuse. So and illegal we cannot put because the fixator is very heavy. So these 3 to 5 years age group the best age for correction of deformity by JACE method. Beyond 5 years, illegal can be taken care of.
Okay, sir.
Saurav, any other question?
No more questions, sir.
Okay, thank you. So my just sincere request to all the students, please learn the technique of plastocasting. As I said earlier, don't leave it to the technicians to wrap the plastocast. You tell them to hold the limb. You try to put the plastocast. Try for simple procedures, putting cast. So by that you can correct many deformities. So serial casting can be used for the finger deformity correction. Can be used for deformity at many joints, especially flexural deformities. So learn the technique of plastocasting. It will be helpful in future in your practice. So if there is no more question, sir, with permission from Kothari sir and using sir, can we close the session?
Please. Thank you very much indeed.
Okay.
Thank you, sir.
Thank you all the participants.
Thank you. Good night.
Thank you, sir. Thank you all participants for joining with us. Participant of more than 50 indicates that how the interest among the physio students learning of different techniques. And thank you all senior members joining in the webinar and encouraging us for organizing this. And I must thank office bearers of IAPMR and for providing us this Zoom platform for organizing this webinar. Thank you all once again. Namaskar.
Namaskar.